Anyway, so the topic for today is liver transplant in the elderly. So we have been talking about this in the context of kidney transplant for the since yesterday, and the problems are very similar, but a little different. So what is elderly is defined by three agencies. One is the World UN defines it as more than 60 years. WHO defines it as either more than 65 years, or for developing countries, if the median life expectancy at birth, if any person exceeds that, then they're called as elderly. And the EU defines it as more than 65, similar to WHO, but also has a definition of very old people, which is more than 85. Most literature for liver is around hovers around 65, but there is some literature which goes around 70 also, with a cut of 70. So this is the evolution of liver transplant in the European Union, where you will notice that the pink bars, those are the ones that are more than 60 to 70 years old, and that proportion in the population is increasing, which is similar to what is there in the US also. And here the bars are the absolute numbers and the red line is the percentages. So almost 25% of all transplants in the US and also in Europe, they are done for patients who are more than 65 years of age, which is a very significant proportion now compared to the past. The other thing that has changed is because of the good antiviral treatments that we have, the hepatitis B and C is declining, on a decline. Unfortunately, since the pandemic, the alcoholic liver disease and NASH are on an increase. So that is another disturbing trend that we see. So now you have an elderly patient with lot of comorbidities who is your, one out of four is one of those patients. So in the past, we didn't really worry about liver transplant a lot, because once you fix the liver failure, the patient was fine. But now we have the same problem that kidney transplants have, is the patients have, is that you have a patient where the liver failure is just one component of the problem, and the metabolic syndrome is the real problem underlying the whole thing. And so, but thankfully over years, the results of transplants have improved. So transplants done for elderly earlier, like in 2005 or 2010 era, were inferior. Now we have better results, obviously because of the several improvements in post-op care especially. Even for HCC, this is true. Although the pattern is that now we realize that not all centers are aggressive about offering transplant to elderly patients for HCCs. And most low volume centers are the ones actually who do it, because these are very straightforward cases to do. They don't really have liver failure, so they have good outcomes. But the more and more centers are now offering liver transplant to patients with HCC, liver cancer. And why do these patients drop out of the list, or which are the patients who are unable? So with time, we realize that as patients age, less and less of them are able to undergo the transplant, the last one, the blue line, compared to younger patients, both for HCC as well as without HCC. And a lot more patients, proportion of patients die without the transplant in this age group, which is understandable, because a lot of these patients will die of comorbidities rather than liver failure compared to younger patients. So overall, their outcomes are inferior to younger patients, which is also obviously understandable. And if you notice, in the short term, the outcomes are actually not that different. So up until 1 year, the results are very similar, which we are going to talk about a little more in detail. But as time goes by, of course, a 70-year-old person who undergoes transplant maybe 20 years ago has a very high risk of dying because of comorbidities rather than liver failure or graft-related problems. So this is a very interesting study. What they noticed is that their mortality actually is very similar for the first 5 years. And at about 8 years, their mortality increases. So there is like a phenomena which obviously is difficult to explain, but basically what we are saying is the patients who have a transplant at around 70 or more than 70 years of age, they will have a high risk of mortality at around 80 years of age, which is understandable because that is the time when the median life expectancy will anyway be high. And the reasons for graft loss initially are obviously similar to other patients, where initially it's because of intraoperative problems, but later it's because of either HCC recurrence, de novo tumors, and infections. So these are the three reasons why they have mortalities 3 to 5 years down the line after the transplant. But still, is it worth doing? It is, because compared to patients who are on the waiting list, who have been denied a transplant because of their age, they do much better. So there is a significant improvement in their transplant, in their survival if they get a transplant compared to if they are unable to get a transplant because of any reasons. And the ones who are denied transplant have a high risk of mortality just within the first 1 or 2 years. And this is also true for HCC, so they have a better survival compared to even liver resections, which has been very well proven in the younger population. So based on this, both the American Society of Study of Liver Disease, ASLD, as well as EASL, they recommend that in absence of significant comorbidities, patients' chronological age should not be an absolute contraindication for liver transplant. And this is borne out in several studies where we know that although the short-term results are very similar to younger patients, but the long-term results are inferior. And then even with propensity score matching for overall as well as alcoholic liver disease, this is true. So short-term results are similar, but long-term results are inferior. What are the things that influence this? So this is similar to our, this is for overall survival, and there is cancers and other comorbidities, especially cardiovascular and infections, are the causes of mortality in these patients in the long term. In the first year, it's more liver related, and which decreases to almost zero beyond the first year. But again, reiterating what has been discussed so far, aging is not just chronological aging. It's frailty which is part of aging, which actually is kills these patients. And there are several ways for us to measure it, and there is a very good validated score which a lot of centers use, is the liver specific frailty index, LFI. And that, in addition to that, we use a CT scan for almost all patients. So therefore we also have sarcopenia, which is measured on the L3 level in the CT scan. So based on this, basically we use the frailty index, and then there are several other indices that we use. But so one is physical frailty, global frailty, and sarcopenia. Based on these three, we are able to give them a good prognostication. So basically the frailty depends generally on the severity of liver disease in addition to age, but age also determines your comorbidities. So based on all these factors, we are able to give a good prediction of what outcomes are expected. In addition, so and then the other factors that have been known to be important in outcomes in these patients is a longer cold ischemia time for disease donor transplant, which adversely affects the all patients, but especially this group. Then there is grade 1 or more, like grade 2 or more diastolic dysfunction. So these are the patients who have normal ejection fraction, which is what all us, the surgeons, especially see. We don't pay attention to diastolic dysfunction as much, but diastolic dysfunction does make a difference. And then if you use normothermic perfusion, which is fast becoming a norm for evaluation of extended criteria or elderly livers, if you use these livers for elderly patients, it doesn't have any adverse effect. So you can safely use these livers for elderly patients. Elderly patients who have psychiatric comorbidities, they have worse outcome, which could be any of those, risk adjustment disorder, depression, psychiatric medication use, pain prior to transplant, chronic pain prior to transplant. So all of them prognosticate a poor outcome for these patients, both mortality and graft survival. So this is an interesting review article where they literally looked at everything. This is a study from Brazil published in 22. And overall, you will notice the same thing, that irrespective of what cutoff of age you take, the 1 year survival is generally around 80 to 90%, which is very similar to what you would expect for overall transplant. And 5 year survival is around 50 to 70%. Now, this is inferior to what you would expect in a standard transplant, a younger patient. Now, the next thing is immunosuppression. So we know that the early outcomes are similar, but the long-term is comorbidities is what we need to prevent. Now these are again, as we discussed, cardiovascular cancer, CKD, recurrent liver disease, recurrent malignancy, and all that. So what we, after review, what I learned is that these patients do have a lower risk of rejection compared to standard patients. So therefore, you can get away with very low immunosuppression. Now, how do we try to adjust immunosuppression? One is that CNI is CNI reduces with because the metabolism of reduces with aging. So therefore, you need to give less CNI. So they will they won't metabolize it as much. The clearance of steroids also decreases with aging, and hypoalbuminemia affects both steroid as well as MMF metabolism. So therefore, you need less doses of all of this. The metabolism of mTOR inhibitors, basiliximab and ATG is not affected. So, and these patients are more vulnerable to immunosuppression related complications. And there are several mechanisms that have been described for these changes, and I'm not going to go through those. But these are the things that you can do. You can lower the doses to achieve similar levels. You can monitor them more closely for neurological complications. For MMF, no adjustments are required, but reduced dose of MMF reduces CMV infection. A reduced dose of steroids is easily possible, but depending on the albumin level, because sometimes these patients do have low albumin levels, you have to adjust the dose of steroids if you're giving them. Most patients will not be on steroids after a liver transplant in the long term. For other drugs, no adjustments are necessary, but they're anyway not often used. So that's my summary. The liver transplant for elderly has equivalent outcomes in the short term, but inferior outcomes in the long term. Their candidacy should be individualized based on their comorbidities and their frailty. Long-term outcomes are poorer because of mostly comorbidities and cancer, and not really because of graft failure. So biological or physiological age rather than chronological age, what is should we use? So we, in addition to age, we factor in the frailty index, we factor in the comorbidities, and sort of then consider their candidacy. And immunosuppression should be individualized to minimize side effects. I'll tell you at this point that I have at least 10 to 12 patients who are only on tacrolimus 0.25 milligrams once a day for the last 3 to 5 years, and their grafts have not rejected once. Thank you.